again to treatment planning, and Nicole and I have entitled this slide presentation Principles and Practices. And so I kind of like this title because I think it expands what we're doing beyond just treatment planning, which is usually just the document that describes treatment planning, but principles and practices underlying it. Okay, so let's, Nicole, go ahead to the next screen here. And I guess it's just what are we going to do today? We want to talk with you just for a little bit about what is treatment planning. And Nicole and I have this lovely picture up here of runners because Nicole and I like to run. And so this is the start line of this course, I guess. I guess the syllabus maybe was, so this is like mile marker 1 in a marathon. Do you ever run a marathon?
No, I'm hoping to do a half marathon this coming spring, but 10K is the furthest I've run.
So I think I'm going to do a 50-miler this summer.
Really?
Yeah.
That's awesome.
Yeah, I'll need some treatment planning for that. All right. So on to the third slide, I guess. So I just want to say, Nicole, that I remember back when I was first coming out of my master's program, and I was doing my post-master's hours towards licensure. This would have been in the early 90s, right? So this would have been like 90, 91, 92. Treatment planning was very different than it is now. It was still kind of, I think, a lot in its infancy stages in some ways. And so I can remember not getting really good mentorship and guidance from my site on how to do treatment plan, not even how to do notes. Like my supervisor, no kidding, he would write in his notes oftentimes, because I would read his charts to try to learn how to do charting. And he would write after a session with a family or a client, he'd say, same as last week. That's all he'd write, one word, one sentence, and then he'd date it and sign it. And sometimes you could look at his charts, and all of his notes were same as last week, same as client showed up, same as last week. And there was no trying to capture what really happened in that 50-minute session, and there was no attempt to try to link that note to a treatment plan. And so it kind of takes me back to this historical perspective that says that, really in the 50s and 60s, treatment planning was really just kind of a here and now event. We're going to do what you come into the session prepared to do, and that's what we do. And there was no thought about how many sessions will it take to help this person work through their issues of grief and loss, or anything like that. And so, in some regards, the idea, if you would have said proposed treatment planning like we think of it today, back in the early days, in the 50s, 60s, early 70s, they would have probably laughed you out of the room and said that this is like anathema. It goes against the grain of a psychoanalytic or a here and now approach. And so I don't know if you've experienced any horror stories in any of your work regarding treatment planning, but if you have any, this is a good time to share them.
Well, no horror stories, but I would say that it has definitely varied based on the setting and what the expectations are. I was very lucky in that my initial degree program that I did was very technical based. It was like a mental health technology program, and they really hammered treatment planning and note writing and assessment at a very basic, detailed level. And so I feel like that was very helpful for me when I, first went out into the field.
Yeah, boy, that's great. I wish I would have had that because I felt like I had to learn it, right? I had to pick it up on the fly, whereas you got it. So what happened in the 70s and 80s, and certainly as we turned the corner into the 90s, that helped us kind of move to where we are now? And so a lot of it really has to do with, and I'm on the next slide there, two significant movements that pushed us along, and this would be accreditations. So you think like in hospitals, we think of JACO, and I know in a hospital you've been through a JACO audit, and sometimes mental health, there's CARF is kind of like the equivalent in some of the mental health fields. And so also along with that is managed care. And so insurance companies and insurance carriers decided, hey, here's the way insurance historically worked. So people paid their premiums, or corporations paid premiums. So you pay your premium for an insurance policy. The insurance company takes your money and they invest it and they hold on to it and they make interest off of the investments. But they know that whatever they take in, they're going to have to pay out. But where they make their money and they make their profit is in the investment period between you paying in and them having to pay out for services. They're hoping to make interest on their investments and so forth like that. And so as managed care came along, they started to realize that healthcare costs were just going up. Technology and rapid advances for everyone was improving people's lives, but it was also becoming costly. And so the insurance companies were paying that money out almost as fast as it came in, and so they weren't able to hold on to it and make any profit for it in a while. So managed care really then became their opportunity to say, well, gee, does it really take 78 sessions for Mrs. Jones to work through her depression about loss of her husband? Maybe it does. I don't know. But managed care started to say, can you do that is it possible to do that in 30 sessions or 20 sessions? And so managed care was kind of a movement to say, are we managing the care of our patients and clients? And I suppose from the insurance end, they had a revenue model behind it, but from an ethical side standpoint, it also was, are we paying for things that can be done at a more rapid pace and just as well? And so that, I think, along with hospitals and their accreditation movements and trying to standardize levels of care and quality of care in hospitals and mental health settings, is kind of like two big historical pieces that kind of drove that along. I guess we can go to the next slide here. I'm keeping an eye on my clock here, and my clock dialed out here. Just a second. Okay. So the question on this next slide that I have for us all to think about is, well, what is treatment planning? and I think treatment planning really depends upon your perspective, right? So if you're an insurance company, as I just said, treatment planning might be how rapidly can you get the client from in the door and out the door? Because it's costly every time they come back to you. And so if it's possible to help people get through bereavement issues in a certain number of sessions, let's work towards that. Treatment planning might be a different thing if you're working in any of these other areas, like a large community-based mental health agency. What does it mean to think about treatment planning from a Christian perspective? So now we're starting to introduce our Judeo-Christian roots and our ethics, and so what is it like to think about what is a treatment plan from a client or a patient perspective? I bet a lot of our clients don't even realize that there's something called a treatment plan in their chart, which is really a shame, isn't it? So I'm getting a little. Are you hearing that?
Yes, the fan on my computer is picking up with the recording. Is that what you're hearing?
Yeah. That's all right. Let's go to the next slide here and see what it's like. And this is a slide that it's kind of a vignette that is real world. It kind of came from a case that I'm kind of manipulated. It happened to me. So here's Marcia, age 41. She's been active as an individual counseling for approximately 10 weeks to address profound grief and loss after her husband and 2 children were killed in an automobile accident that occurred approximately 3 months prior to starting counseling. At the close of the most recent session, the counselor suggests that it might be beneficial to spend a part of the next session revisiting the treatment plan they originally put in place on the 3rd session. Afterwards, Marcia found herself thinking about that strange phrase, treatment plan, and wondered what she had missed or forgotten. As her wheels were turning, she started to wonder what exactly was contained in that chart the therapist held on his lap towards the end of each session. So I remember this client. I've kind of changed some of the details here a little bit, but I remember coming to the session that we were going to talk about the treatment plan, and she had, at this point, we had a good therapeutic relationship, and so she said, I don't even know what a treatment plan is, and I vaguely remember us talking about this way back at the beginning of treatment a couple of months ago. And yeah, I guess I signed something, but I signed a lot of papers when I came into your office initially. And so I remember that was a moment for me to think that, the client thinks that we have this mysterious power, whether it's the MMPI we administer or a Beck depression or the notes we keep in our chart. And I think a lot of what we should be doing as therapists is demystifying this stuff. And really it's taking down a boundary. It's taking down a wall between us and our client. And so our client, I think, has a right to really know what that chart is and how it functions, and what are the limitations and what are the strengths of a good chart. And I remember having a wonderful conversation that has really changed how I think about the chart. And I want my client to know what it is. And I do put my chart. It's a habit. I pick up the chart and I put it on my lap. And I kind of do it on purpose to kind of communicate non-verbally to the client that our time is wrapping up. And so I always, with about 10 minutes left, I grab the chart and I'll put it on my lap and I'll just hold it there. And they know that's a cue for them that it's time, that the session is almost over. But what I've now tried to do is let the client know what goes in that chart and be more clear with the client about what is a chart supposed to be doing and not doing. I don't know what I'd do if I worked in electronic medical records. I guess I can put my laptop on my...
At my practicum site last semester, everything was on the computer, and they actually provided us with rolling stands and our computer, and the expectation was that we did our intake in session with the computer, and the client signed it at the end. Same with the treatment plan. It was my first time ever as a clinician having a computer between me and the client, and it definitely took some. So I kind of would put it off to the side, had to think about how am I being open and using my good counseling skills with this computer between us. So
electronic medical records have really changed our interaction. I'm not sure it's for the better or for the worse, but it's definitely changed it. Mm-hmm. And it can be a boundary for sure. And I've seen psychiatrists who are just typing the whole session, right? Mm-hmm. And not even looking at you. They're like, maybe they look at you like that, and then they go back to their keyboard, right? Which is probably not good.
Right.
So, again, the next slide, assumptions. So when it comes to treatment planning, I think the goal of this is behind treatment planning. And those assumptions really depend upon the key stakeholders, whether you're the insurance or whether you're the clinician or whether you're the client, whether you're a big community agency, whether you're a substance abuse treatment center or a hospital or a private practice. This is all like coloring your understanding of what is a treatment plan and how to do it. So there's a lot of key stakeholders involved in this. But I think, though, part of the assumptions of treatment planning is that there are mental or emotional psychological disorders that can be treated and in a measurable way, right? So that we do a treatment plan because we believe there's a process that can lead us to some kind of better place for the client than when they came in to see us. So this kind of then brings up the question, what is the best way to treat a special condition or a disorder, right? And so, and there's a lot of debate about that, right? So somebody might say CBT is good for a certain kind of condition or disorder, and someone else might say, no, not CBT. Well, this is a hardcore behavioral issue. And so we'll talk, I think, about in the class about what are best practices and what can you do and not do and be safe in your practice, right? And so if you're the only one doing it, I always say I wouldn't do it. So I remember when I was talking with a lawyer, consulting with him about doing counseling online. He said it's okay if you're doing it within your state because you're licensed by that state, but he said across state lines he wouldn't do it because, and if you get sued, you're going to get sued in both states. You're going to have a real legal battle. How are you going to, if I get sued in Wyoming, I got to figure out how to have a lawyer to defend me in Wyoming as well as a lawyer to defend me in my home state of Virginia. And he said just it's too prohibitive. And so I've never done telecounseling because there's no case law for it yet. I know other people are, my suggestion is, no matter what your treatment is that you're doing, you don't want to be out there doing it on your own and be the Lone Ranger. You want to be part of like a larger community of people that are delivering the kind of services that you're offering. So this kind of brings up the question, though, of like in treatment planning and what it is and assumptions about it. Is treatment indicated for your client? Sometimes I have clients or individuals who, after the initial assessment or a session or two, I realize that the treatment that they're wanting, it isn't indicated, or I can't provide it, so I need to refer them out, or maybe tell them I don't think treatment's indicated. What kind of treatment? How long will it last? General levels of intensity or emotional distress. These need to be considered. What is the prognosis for positive change, right? So these are all kinds of questions that I think that we should be asking when we think about treatment and considering treatment. I'm going to just check on our time here. What are we at? Probably about 15 minutes.
Yes, I think so.
Yeah, we're going to go just a couple more slides, and then we're going to end this today, I think. So other thing about is, I think from a Christian worldview, this bottom point here is, how do we determine what's true or relevant to our topic? It's at hand. And so for those of us that are also trying to bring our faith into play, and our faith informs our counseling and our worldview and how we work with clients, so we have to kind of think about our faith. We have to think about science. We have to think about revelation. I think at some point here in the semester, I'll try to come back to what I like to talk about is Wesley's quadrilateral, which is a way of like making sense of all these different perspectives, I think, in a Christian kind of. So what is truth? So on the next slide, I have this like great statement. Holy cow, Dr. Newmeyer, are you telling us this is a class on epistemology? Yes, of course. We have to think about this stuff. We have to think about what is true for our clients. And so Matthew 6:21 says it like this: for where your treasure is, there your heart will also be, right? Will be also. And so I think that one of the endeavors of a Christian, of a counselor, of truth and how it guides your decision making. On the next slide, a quotation in a book by Mark Yarhouse, what is clinically relevant. So your values, your client's values, your clinic's values all shape what is clinically relevant, what a clinician sees or doesn't see, what clinical evidence is salient, useful, or otherwise important. So I'm going to stop there. You can read the rest of this, but I can remember working on a team with a psychiatrist from Johns Hopkins. And if anything you know about Johns Hopkins, they are hardcore behavioral. And so I kept talking about how the clients feel about this treatment protocol they wanted to do. And they would just like dismiss me. And finally I kept, well, how's the clients going to feel? Because it seemed like a very punitive model of treatment they wanted to do. And finally, I remember this Hopkins doctor stopped and he looked at me and he said, Mark, we don't care how the client feels. With the right behavior intervention and reinforcer, we can get any behavior from the client we want. And now that's a hardcore behavioralist, right? And that's a very different value system than probably most of us in the counseling field are trained in. But it is a noteworthy, a hardcore behavioralist. His outcomes may be just as robust as mine, maybe better. And so I like to think that our values really do shape. His value was, I don't care how the client feels. I'm looking at the person in terms of a mechanistic kind of approach. With the right reinforcer and modification schedule, I can get whatever whatever behavior I want out of the client, and they will be compliant with it. And so we need to think about, like, where are we on these continuums of thinking about things? Nicole, I'll just stop and see if there's anything you want to add in here.
Well, it just reminds me of a conversation we had when I came to Virginia Beach in October for the CAPS conference about values, and how as counselors, we really can't separate our values necessarily from who we are as a counselor and how we interact with clients. And I think that's especially important to keep in mind and think about how our values then are influencing our treatment planning. And so, we have to learn how to bracket, and there are ethics to consider, but we also still do hold values as a person, as a Christian, as a counselor. And so thinking about how to integrate that, I think is especially important with the treatment planning piece, because really our values are influencing how we're conceptualizing the case.
Yeah, yeah. So this kind of brings us to so if you go down to like slide 13, more on treatment planning. I'm skipping a few slides, folks. Please read through my slides. But lifelong learning, right? So I think Nicole and we would both be quick to say, be lifelong learners, right? And so I think probably Philippians here points to the fact that yes, we can reach a level of maturity, but maturity, I think ultimately the definition of maturity is a willingness to continue to be made mature. and so it's a process, right? And so maybe I think of J. Vernon McGee. He talked about, he was going to talk on the topic of sanctification. He said, now there's a lot of things that people think about sanctification that are different across denominations and Christian groups, but he says there's one thing we can all agree on, and that is we're all behind in getting it. And so I think we can all agree that we need to think more seriously about what is true, and what is true as Christians, what is true in our practice as counselors, and how can we continue to mature and grow. I think the last, I don't know if I have, okay, so if you go down 2 slides further, I'll kind of tip you towards my bias. So treatment planning requires. So treatment plan, this is my bias, this is where I'm at in my maturity right now, and that is that I think good treatment planning requires a consideration of these different areas, so bio, psychosocial, spiritual. And so if I'm working with a client on intake, or if I'm working on that, we've been working with them for a while, I'm always mindful of the biological, the psychological, social, and spiritual. Sometimes I wrap this all up and I call it my ecological counseling hat, and that's my training and my bias is ecological. But when I say ecological, I really mean attending to all of these, and that the client has to miss what's biological about the client and think that I can just like help them with psychological assistance might be really doing disservice to the client, right? That I can work with the client and not think about like their family system or the larger systems or the social presses in their lives or their spiritual side. So this would be my way of looking at it, and I think probably most people in our profession this kind of process. And so as we go throughout the semester, I think one of the things I'll do is emphasize how to kind of tease these different things out. Last thoughts to stay within our time frame here?
I would just say that that's how I conceptualize. I actually have a statement to this exact topic on my webpage for my advertisement for my private practice. So we're on the same page.
Good. I don't have to fire you. We'll put that on a treatment plan. Okay, folks, we ran through these slides really quick. If you're doing the readings and you've listened to this YouTube, you should be in a good place as we move forward in this class. Thanks for joining us in this YouTube. Thanks, Nicole, for talking with me about this.
Yep, it was great. Thanks, everyone.